Hello, and thank you for joining us. My name is Kathy Barnard. I am a melanoma survivor and the founder of Save Your Skin Foundation. I welcome you to today's webinar presentation about melanoma skin cancer news from the European Society of Medical Oncology, otherwise known as ESMO Congress 2020, which was held virtually this year. I am so honored to have with me today Dr. Reinhard Dummer, all the way from Zurich, Switzerland, although virtually. Dr. Dummer is going to review late-breaking news, key takeaways, clinical data, and other updates presented at ESMO in the last month. And he will share his key insights into what the landscape of melanoma and non-melanoma skin cancer treatment looks like for the near future. Hello, my friend, Dr. Dummer.
Thank you very much for the kind invitation. It's a pleasure to be with you and to summarize some results from the ESMO Congress that was also a virtual meeting this year. So I share my slides with you. There are a few topics that are obviously important for melanoma patients. And one of these topics is the combination of targeted therapy and immunotherapy. You know that we have improved the outcomes of melanoma patients tremendously over the last 10 years. On the left-hand side, you see survival curves from 2011, and you see, unfortunately, at this time, we could only help a minority of patients. And nowadays, with the use of targeted therapy and immunotherapy, a substantial proportion can be treated successfully, and some of them, and I would dare to say so, can be cured. So if we have two successful treatment options, you definitely would consider to combine both of them in order to get more benefit for your patients. And we know also from preclinical work that there is a lot of arguments that targeted therapy is damaging melanoma cells, that these melanoma cells then get better visible for the immune system, mainly T lymphocytes. And in this interaction, we expect to see a better outcome of targeted therapy if the patients get at the same time immunotherapy. And therefore, there were a number of clinical trials who have investigated the combination of targeted therapy with immunotherapy versus targeted therapy alone. And one of these projects is this project sponsored by Novartis. It's a clinical trial comparing an anti-PD-1 molecule, spartalizumab, in combination with targeted therapy versus targeted therapy alone. You see here the study design. So in this clinical trial, more than 500 patients were included. Half of them received placebo plus daptram, which is the targeted molecules, and the other half received spartalizumab. And the primary endpoint was investigator-assessed progression-free survival. So how many patients can be kept in disease control with the two treatment arms. The patients were randomized, so this means that we have a very well-balanced distribution of risk factors. You have heard that, for example, blood values such as LDH are important. If you have LDH, elevated LDH, there is a higher risk that the disease is not responding to therapy. Therefore, it's important that these risk factors are evenly distributed among the two treatment arms. This is the patient disposition at the moment, and you see one important finding. Most of the patients had to discontinue because the disease progressed. However, in the triple arm, 20% of the patients had to discontinue the treatment. And this means that there are a number of adverse events occurring that limit the use of the triple combination in this patient population. Here you can see the comparison of the progression-free survival in the two patient population. You see that there is a minor advantage for the triple therapy. However, if you do a proper statistical test, this is not significant. So there is doubt whether this treatment is useful in the overall patient population. You can look also on subgroups who is profiting more from the triple in comparison to the double therapy. And here are a few interesting points. So patients with a more aggressive disease, characterized by large tumors, by high LDH, and also by stage 4, have a better, more benefit than patients who have less aggressive features. So one argument could be in the future that this type of therapy is only useful in patients with advanced disease. There was also, and this is surprising, that already at this time point we see an advantage in overall survival. So we could keep more patients alive with the triplet than with the placebo. However, this difference is quite small. And with this, the question is this clinically meaningful for our patients? We wanted also to know, is the second-line treatment important? And I think the second-line treatment is really relevant because more or less all of the patients who progressed received additional therapies, and many of them immunotherapy. And this is especially important in the control group because this treatment can help to compensate for treatment limitations in the randomization phase. Here is a short view on the response rate. You see that the response rate is around 20% in the triple arm and very similar also in the targeted therapy combination arm. Actually, we would have expected more responses. We have done a so-called biomarker cohort study for in the early phase. And in the early phase, we have seen more responses with triple therapies more in the range of 40%. So in this randomized part, we did not see this very high and promising response rate. I mentioned already that a lot of patients discontinued, and this was really an important feature. We had a number of adverse events, treatment-related adverse events, and many of them led to treatment discontinuation of at least one study drug, but also in the there were some patients where all three study drugs had to be discontinued. And I think this is maybe one of the limitations when we talk about the differences. One of the reasons why the differences are small could be the reduced tolerability, leading to a lot of discontinuation cases and dose interruptions and dose adjustments. So we can conclude that despite very promising preclinical work, this clinical trial did not meet the primary endpoint. There was some improvement of the overall survival and the progression-free survival, but we are not convinced whether this is really justifying the increased toxicity that is observed with this treatment approach. Well, if you cannot give immunotherapy and targeted therapy at the same time because of adverse event, you might do it sequentially. So this means you might give first targeted therapy and then immunotherapy, or the other way around. And this was investigated in this investigator-initiated trial led by Paulo Asierto from Naples. And you see here the different treatment arms and the possibilities. So the first one goes with targeted therapy first. If this is not helping any longer, you switch to immunotherapy. Here, the combination of ipilimumab and nivolumab. In arm B, it is just turned the other way around. You start with immunotherapy, switch then to targeted therapy. And then there is a new approach, which is called the sandwich. Here, the patients start for 8 weeks with encorafenib and binimetinib. And at this time point, the targeted therapy typically still works. and has reduced the tumor burden. And despite a good effect, the patients discontinue with the targeted therapy, switch to immunotherapy until the disease comes back, where they can have another treatment with Encubini. So this is like a debulking strategy. So if we have a patient with a lot of melanoma lesions, we give him targeted therapy in order to melt down these tumor lesions, and then we start the immunotherapy. You might know that immunotherapy is not working so well if you have very advanced disease with high LDH. So you try to correct for this using the 8 weeks of targeted therapy. And here we had some data presented in this clinical trial. Here you see the outline of the patient population. So overall, more than 200 patients were included, which gives around 70 patients per arm. Actually, we have to say this is not enough, probably. We call this underpowered. So we feel that this clinical trial is underpowered, and therefore the overall results will be difficult to interpret. Here we have some results. Here's the first progression-free survival. Here you see what happens to the different treatment arms. So typically, targeted therapy is working very nicely, and the progression events come slowly over time. With immunotherapy, we see a lot of progressions initially, but then later on we see a stabilization, which is very typically, and the arm C is somehow in between. And now we see something on the toxicity in these patients, and the response rate here, you see the response rate is quite promising. So between 15 and more than 20% responses, complete responses, I think is very encouraging. And there's also a decent number of patients with a high number of partial remissions. And then due to the switch, there's also the progression-free part 2. And here we have the overall observation of the second part. And what you can see here is that Ipi/Nivo is performing very nicely, and the duration of the response is as expected, very good. The toxicity was as we have expected it. So immunotherapy causes a lot of adverse events, but experienced centers know how to deal with this. And then if you follow the patients longer on and wait until the progression-free survival event 2, you can see that then in a lot of the patients, the disease is controlled. And the arm C, which is the sandwich arm, seems to do pretty well. So it looks like a very encouraging result. However, we have to say that at this time point, the results are immature, so we have to wait and see. And unfortunately, and maybe also connected to the size of the clinical trial, there is a little imbalance. So there are differences in risk factors in the different arms. So I'm sure that you will hear some more of this clinical trial in the near future. And then we have an interesting project. So we talked about targeted therapy and immunotherapy, and it's very difficult to say what do you offer the patients if this fails. And this was investigated in a clinical trial using a multikinase inhibitor called lenvatinib. So lenvatinib is impacting on the vascularization. So if a tumor is growing fast, then he needs to create new blood vessels. And in this process, lenvatinib is active. And if you control the angiogenesis, then it should be better for immune cells to control the tumor. So there's quite a strong rationale for this combination. And this medication has, in very heavily pretreated patients with melanoma, also shown some responses, short responses, but some responses in pretreated patients, as you can see here. So it makes sense to investigate this product, lenvatinib, together with an immune medication, pembrolizumab, and anti-PD-1 antibody. You can see that here up to 100 patients were included. The primary endpoint was overall response rate, secondary endpoints, duration of response, and progression-free survival. So more than 100 patients were included. And then you see also many of them are available, and a lot of them had already to discontinue this treatment. Here are the characteristics, actually marked here, the LDH and the brain, and the sum of targets, target lesion. And this tells you that the patients that were included in this clinical trial had a very advanced disease. And from my opinion, I have to say that many of them probably have been very, very sick with fever and very bad conditions. And this is also reflected by the pre-medications. You see many of these patients had more than 2 pre-medications, so they have already failed a number of treatment possibilities for advanced melanoma. But nevertheless, we observed some responses, so even 2 complete remissions, which goes to close to 2%, and 20% partial remissions. So the overall response rate is around 20%, and I think this is not so much, but for the patient population, this is encouraging. You can also see that the duration of the response is appealing. So it's at least most of the patients, it's more than 6 months. We know that many of these patients nowadays are treated with the ipi-nivo combination right from the beginning, and there were also a decent number of patients pre-treated with this combination, usually 29, and the response rate in this combination pre-treated patients was even higher than in the other group. Who was benefiting? You can see that the higher response rates were seen if patients were in a good general condition, if they have a lower stage, if they have a normal LDH. So the general features of good prognosis are still relevant in this clinical trial. Here's the progression-free survival, and you see the death rates at certain time points. And you see here also that this treatment has quite some adverse events, which are sometimes not easy to handle. And here you see a more detailed list. So one of the very common adverse events is hypertension. Another one is hyperthyroidism. So thyroid disease is very common also if you treat with PD-1 alone. And then a number of other adverse events, including skin toxicity or hypocalcemia. So at the end, we can say, if all treatments, all standard treatments are not working, we have now candidates to improve the overall outcome, and this includes the combination of lenvatinib and pembrolizumab. So interesting data, but still I think they are not changing our current guidelines. So our current treatment recommendations say we could go for immunotherapy first if the patient is fit for that, and we keep targeted therapy as a rescue therapy if immunotherapy is not working. And I think there are some arguments that this is correct. Here is analysis of patients who received a complete remission with the combination of ipilimumab and nivolumab. And the interesting point in this context is the comparison of patients with ipi-nivo combination versus PD-1 alone. And look how many patients have discontinued due to toxicity, and this ipi-nivo combination, this was 52%, and in the other group it was, in the PD-1 group was only 20%. And the other interesting point that we see that many patients had discontinued treatment after this due to toxicity very early, and still are profiting from the complete remission. In another big data set investigation, there was the question well, what happens if you have adverse event? Are you doing better if you have a lot of adverse events? I sometimes also tell this my patients, and there are some investigations who claim that this is true. Here is a larger population presented by Dr. Hamid. And what he found is that it does not matter whether you have adverse event. All the patients are profiting the same, independent whether you develop adverse events or not. I think interesting observation also. And here is the summary of this. So the efficacy of this monotherapy PD-1 was similar in patients who received also corticosteroids due to adverse events or did not receive corticosteroids. So this is also encouraging for us that we can use immunosuppressive medications such as cortisone if a patient is suffering from adverse events. And finally, two other indications in the skin cancer field. So one is a vascular tumor that is called Kaposi sarcoma. So Kaposi sarcoma get famous with the HIV epidemic some years ago. When these patients developed reddish spots, but it can also occur in the Mediterranean Sea in elderly men. And this is a patient population that is very rare and has actually no really approved medication. The group around Céleste Lebe, who is a French dermatologist in Paris, designed a clinical trial using pembrolizumab in this patient population. And surprisingly, they saw a very good results with 2 complete remissions and 12% complete remissions and 59% partial remissions. And you can see here, many of the responses are coming quite early. So this is really a powerful treatment for patients with Kaposi sarcoma. And actually, many of them are now treated with interferon, and interferons will disappear. They will no longer be on the market. So it's very good to have treatment options for these patient populations. And then another study focused on basal cell carcinomas. So basal cell carcinomas typically are treated by surgery or irradiation, but some of them are treated too late or are very aggressive. And then the patients receive hedgehog inhibitors, which are tablets that interfere with a basic transduction pathway in basal cell carcinomas, and they work very reliable. But also this patient, this treatment is sometimes not useful any longer. So you need new medications. And one of these medications was cemiplimab. So this is a monoclonal antibody against PD-1, so similar to pembrolizumab or other antibodies. This medication was then used in basal cell carcinoma of the skin. And here you see the results. So there was a significant response rate of around 30%. Some of the responses are occurring quite late, so it takes obviously longer for this tumor to be recognized and deleted by the immune function. So with this, we can say we have now really a new option for patients with basal cell carcinoma, and I think it will be approved in the US very soon. So yeah, I think this was ESMO in a nutshell, and you realize there was a lot of news for patients with skin cancers. Not every story is a success story, but we are moving forward, and I think triple therapy is not yet dead. It's important that we find out who will profit from this type of approach. And with this, I thank you very much for your attention, and just can say, stay healthy in these times, and have a good weekend.
Dr. Dummer, thank you so much. I just want to remind everybody that this webinar was recorded in advance so that we'd have the best use of your valuable time. Should anyone find themselves wanting to ask a question after watching, they can please email me at Kathy@SaveYourSkin, and I will contact you with a reply and any discussion that we wish to have via email. I didn't get to start by giving your bio, but I have to tell you, you are not only my ally in the fight against skin cancer, but you are an astounding leader in this field. I do want to ask you one question. You have been in this space for quite some time, as have I, as a patient. In those early days when you first started and I was first diagnosed, they were quite dark. And I know in Canada in 2011, we started to see a little light at the end of the tunnel. And we were actually talking a little bit about hope. In the last couple of years, and from your presentation, we've seen incredible new innovative treatments coming into our space, which as patients gives us a brighter light at the end of the tunnel. Can you as a physician tell me what it's been like for you to have started in those days of my treatment, interferon, with very little hope, and be where we are today? And for me, a patient that got one of the new innovative drugs in 2007, for you and I still to be here today having this discussion.
Yeah, this is a very important question. And actually, you are right. I'm in the melanoma field for more than 25 years. And I have counted this one. So we have treated more than 2,000 patients with metastatic melanoma in clinical trials without seeing a single benefit. And still, we never gave up. We always thought, okay, the best thing what we can do is clinical trial. Even if they fail, then we have tried new options, and maybe at a certain time point we will get something. And then I feel really privileged now that I could join this endeavor and this positive developments. And I think this has really created a spirit of hope for the patients and innovation for the treatments, and I think it's really worth it. So I am very motivated to go on, and you know, if you have achieved something, you get a little bit more ambitious, and you think, before I leave the melanoma field, I want to get 10-20% more of my patients alive. And I love to see our clinic growing because we have more and more patients that come for a regular follow-up.
Well, Dr. Dummer, on behalf of the thousands of patients and families from across the globe that are friends to Save Your Skin, and myself and my family, I can never thank you enough from the bottom of my heart for the dedication and commitment and the hard work that you have done in this field. It's because of people like you that I am still here able to share. So I say to you, please stay safe. Hopefully you and I will see each other face to face in the future. It's been a few years. I miss seeing all our wonderful physicians. Thank you again for today. And thank you everyone for watching. And this will end the webinar session. Thank you.
Bye-bye, everybody.